everyone. I am super excited today. Okay, right now is the middle of August, and I don't know about where you are, but locally our kids have all gone back to school already, which feels crazy early, but that's the way it is. And we know as pediatricians that we're going to start getting calls in 2 weeks about kids with attention issues and kids do they have ADHD? What do I do? And I don't know about you, but it feels like winter is coming when it comes to all of the kids with the focus issues and all of those sorts of things. And it can often get overwhelming to try and get them all in, get them all seen, get them all evaluated. And we already know the crisis in mental health in this country, period. And then getting them found somebody that can see them for pediatrics that isn't going to put them on a bunch of different psych meds, or just kind of like take what works for adults and try and apply that to kids and have them on these medicines that you've never heard of, with all the side effects and everything like that. And so I'm super excited today to get to talk with Angelica Robles. She is a developmental behavioral pediatrician in Charlotte, North Carolina, and she is on a mission to help empower primary care providers, physicians, to better feel more comfortable with the diagnosis and management of ADHD. And I'm sure part of that is so that you can focus on those really acute cases, those really complex cases, and feel like I've empowered pediatricians, I've empowered family practice doctors to be able to more easily and fully take care of those patients, so that in September, they're able to get evaluated. In October, they can get on therapy or on medications or on both. And it's not, okay, we're going to refer you out and we're going to hope that you can get in by January. Half the school year is gone, yada, yada, yada. This is the longest introduction I've ever done. And so I apologize. Angelica, tell us a little bit about you and your background. And then I just want to jump right into what pediatricians, what family doctors need to know to feel more comfortable with prescribing or making diagnosis, prescribing without having to refer everyone out.
Yes, thank you for that lovely introduction. So
That was
yes,
that was literally the longest one I've ever done, and I just kept talking, and I
No,
felt
I
like I was
appreciate
having
it.
like
It's exciting.
yes, I felt like I was having like pressured speech, like I just can't stop talking.
No, it's wonderful. Thank you. So I am a developmental behavioral pediatrician. So that means I did my general pediatrics residency. After that, I did fellowship training in this field for another 3 years. So when I started my fellowship training, I had to know about ADHD. Obviously, that's a big thing that we see, along with developmental delays, autism, and all of that. But entering my fellowship, I felt like I knew nothing in regards to ADHD. And I was having to see kids for follow ups or new visits where it was like, okay, they want the assessment done, or they're taking this medicine that I've never heard before. What do I do? So it was a lot of learning for me, like a huge learning curve just in fellowship. And then in practice after fellowship, I still felt like it took some time to develop my practice, learn about other medications that we didn't even do yet in fellowship. And so it took me years of feeling comfortable even after all of that. So
Well,
I get it,
I think that's like such a common problem is in residency, you get this academic experience where you're doing a lot of like, okay, I know the Lasix doses because I got to get these kids off, out of the
Mhm.
PICU or out of the cardiology unit, or I know these random chemo medicines and all of these things. But then you get out into practice and you're like, what are the doses for
Right,
Focalin or
right.
Ritalin, or like how do I choose which one is right? Like you just don't get
Mhm,
that much exposure to it. So
mhm.
I know a lot of physicians that basically do whatever their last preceptor in residency did in terms of here's the
Exactly.
medication choices or something like that. Like I don't know, that's just what we used a lot in residency at that one place where I did that rotation where that's what they used and it was successful, and that's kind of how my career has been founded.
Exactly. That's exactly how I was coming out of residency too, is I knew Concerta, maybe Methylene and Ritalin. That was really it. So I didn't really even try any of the amphetamines, non-stimulants, nothing. And obviously I knew how to do a Vanderbilt, and that was kind of it. So yeah, definitely a huge learning curve from that aspect. And so that is why, coming into this role now, I see, kids again get referred to me for ADHD evaluations and consultation, and they're referred. And now unfortunately our wait is about 9 months long. And so that is the whole school year gone. And, it's really just for that ADHD concern. And something could have been done, and I get it. You don't feel comfortable, you don't have the resources, the tools, the knowledge yet, because there is a lack of training there. Like you said, I mean, unfortunately, there's not that much in residency or anywhere else that we receive this information, and it is the second most common childhood disorder, only to, second to asthma. So that's a really common issue that we need to learn more about, but we're just not getting enough training on.
Well, and like the problem is we can't just be like, well, we'll just kind of wait these 9 months and hope that things go okay. I mean, that's not
Mhm.
okay from the kid's standpoint. It's not okay from the
Eh,
parent's standpoint.
Sure.
It's not a good experience to
Hmm.
say, well, there's nothing else I can do. I don't do this. And it would be great if we just had enough mental health providers and enough child and adolescent psychiatrists and
Hmm.
enough developmental behavioral pediatricians to do all the things, but unfortunately we don't. And so it does fall upon us to either say, well, we can't do anything, you're just going to have to suffer through this year, or I'm going to do the
Hmm.
best I can. And, I'm going to try and help you out while we're waiting for this referral to happen.
Right,
And
right.
so let's avoid talking about like the real complex kids that are on multiple medications or have, dual diagnoses or other things like that.
Mhm.
When we're talking about garden variety ADHD concerns, what can a pediatrician, family practice doctor, somebody that's seeing this patient, getting the initial history and everything like that, like where should I start? What should I do to quickly make the diagnosis and
Mhm.
then decide on a plan from there?
Absolutely good question. So it's really a diagnosis we can make using the DSM-5 criteria. So, a good way to go about that is, like you said, making sure we get the proper history to see, is this also happening in two separate settings where it's not just at home? It also has to happen at school, usually, or somewhere else, if they're in a sport or activity after school. And it has to be present for 6 or more months. The child has to be at least 4 years old, and it has to present before 12 years old, and it has to impair their functioning. You have to have a significant number of inattentive symptoms, obviously, or hyperactive impulsive symptoms, obviously, or you could have both, depending on the type of ADHD. But the way to get that history, a good way that's easy and quick, is using the Vanderbilt, like I mentioned, and it's free, easily accessible, because it goes through all of those questions and it tells you how often and impairing that is for the child. And it is also helpful because you can give one to the parent, one to the teacher, to get the two separate settings. And if you score high in either one of those areas, obviously you can, along with further history and getting more details from the parent, to say, okay, if you're seeing inattention, how is it related to what you're seeing every day? Like, how's the morning routine? How does it go when you have to get ready for school? Because then often you'll find there's something going on that's dysfunctional in the morning routine. Or how is it if you tell the child to do something? Do you have to break things down where it's only one step they can follow at a time, and you have to even repeat that one? That can be really frustrating, and the parent's like, am I just a bad parent, or are they just being defiant, right? Because that could be the perception. And also the hyperactivity, impulsivity, that's going to be more obvious. But with the impulses, it's like, how is this child regulating their emotions? Are they getting into trouble because they're doing things without thinking, like hitting or doing something dangerous that is impulsive? Or how's their emotional regulation? Are they having big reactions that are hard to control because it could be ADHD too? You want to make sure you ask about sleep and anything else that could be stressful or anxiety related to screen for those things as well. But I feel like getting that general information can be really helpful.
Well, it sounds like that is definitely something that we can do in the primary care setting. And the thing that I love about it is you don't necessarily have to do it all in your really short minutes long appointment. You
No.
can say, here's the homework.
Hmm.
Once you get these back, we're going to put something on the schedule for 2 weeks from now, and you're going to send me the forms in advance if you can, or you're going to walk them in when you bring them in, and we'll evaluate them and make the next steps from there. And I think that oftentimes what happens is, we want to take care of their problem at that visit. But if we can tell them, here's how we do it. When these concerns arise, we don't want to jump too fast. And parents are very hip to not wanting to jump too fast because I think a lot have the perception that, well, I'm going to go in and they're just going to, throw Adderall at my kid and we're going to go from
Mhm.
there. This is how we do it. We do our initial visit, we get the information, we give you homework, you come back in 2 weeks, we're going to talk about it more, come up with some plans from there. And I think that if you can communicate it in that way to patients, they realize the value of the speedy diagnosis, but they also
Mhm.
don't feel like you're just, a pill pusher that's going to put everybody on Adderall or whatever it might be, that we're making the diagnosis appropriately and being careful and diligent in making sure that we have the right diagnosis.
Exactly. So I did make a PDF, like a cheat sheet, if you will, that has the steps. And that is included in there to say, okay, you can start with a history. If there are the concerns brought on, then you can definitely do a separate visit once you get those forms completed to then go over the findings. And if you have all the information, everything's consistent, then you can confirm the diagnosis and then just talk about options at that point, whether that's making sure we get supports in school in place, like a 504 plan with accommodations. If we want to think about therapy, what kind of therapy is that? And then you can talk about medication too. But I don't like to push too hard on medication as well because I want to make sure that the family's comfortable. We talk about all of the things because it is a whole picture approach we have to take, not just medication alone for sure.
Now, when you pitch that to parents, is the ideal in my mind, and correct me if I'm wrong, would be therapy first, then medication, therapy plus medication, therapy as part of it. Is that a fair statement, or is therapy necessary for a certain subset only of kids with ADHD?
It depends on the age a whole lot. So most kids that are probably coming to you are going to be past the preschool age because we're saying this isn't the complex kid, because complex cases would be considered maybe more preschool age. So those you definitely want to do therapy alone first. For older kids, it depends on the situation, what you want to work on. If it's something where the child is old enough to work on skills themselves, let's say about 7 or 8 years old, where they're developmentally ready to do more cognitive or talk therapy, where they can work through organizational skills, strategies for themselves, coping, then, I think that in combination with therapy can be really helpful. If they're, maybe around 6 years old, slightly younger, parent child interaction therapy can be really helpful, because you want to find those effective parenting strategies that can then carry over and you can use them as a child gets older too and understanding the child better. There's a little bit of a gray area though between like 6 to 7 or 6 to 8 years old where there may not be something in that time period that is as effective other than maybe family counseling again to get more strategies that can help the parents know what to do that helps with their child. But it depends on everyone and what works best for them. It's very individualized. And so I always say therapy is always good to think about and to try regardless, because I do think a combination is always worth trying.
It's for some families, for most families, the time commitment and the financial commitment and finding a therapist that has any availability, before the next Olympics
Yeah.
is a challenge. And so oftentimes it seems like, okay, well, we don't want their whole school year to be a bust. We don't want them to wait. Perhaps if we start them on a medication, then they will have the opportunity to work on those skills either in the home setting, in the school setting, or just de novo because they're, not so all over the place. Do you think it's okay then if we have them come in, we get the initial history, we give them the homework of the Vanderbilt, they score high, we are plus or minus therapy based on all those different contexts, then to start a medication from there if they're meeting the criteria?
Absolutely. So, especially at that point, the child is probably not functioning as well as they could. It's impairing them every day. absolutely talk about medication and how that can be something that you start to help with that everyday functioning, help the child feel better, hopefully their self-confidence improves if that's starting to be effective. Because if we don't do that, that can snowball into more anxiety and other mental health concerns. So I think it is worth trying if we do, especially have to wait for a therapist or a counselor. Like you said, unfortunately, everyone's backed up in mental health these days. And so having that in place to help them along the way as they're waiting for that to start can be helpful. And I know sometimes school can also provide counseling services, but again, it depends on what resources are available and the school itself.
Right. I think that my pitch to parents is often it would be great if all of these things were in place. If you had time after school every day and you could sit with them and do your homework and you had unlimited resources in terms of finances to have a therapist, all those things. Most people don't live in that world, and so we're going to do the best that we can, and using medication is likely going to improve things in the short term, improve their scholastic achievement, improve their self-confidence, improve their organizational skills, so that then we can work on all of those long-term lifelong coping strategies for our inattention, our focus, our impulsivity.
Definitely. And I like to say, we can start this now. We can always decrease it. We can change it in future. The goal is to do the least amount of medication needed because we want these other tools in place. And as time progresses, we could see improvements as the brain continues to develop. But I meet parents where they are. Like you said, if we can't do therapy because, of time and work and school, you have to help them the best that you can. And sometimes that means adding medication. And I think that is a good approach because you are giving that child what is helpful for them in that moment. And it can be so helpful for not only the child, but the family. As a dynamic, things can get so much better. The stress level decreases. They can build their relationship to be more positive. Some parents say, I wish I would have done it sooner because maybe they were hesitant to start at first. And like it has changed our world for the better so much. We wish we would have done it that first time or that first visit we talked about it. So a lot of people, I think for the most part, there's exceptions to everything, generally have a good experience once we do that. And I talk them through it, what to expect. You have to talk them through, what to expect with the medication, what it's going to look like, how long it lasts, what to look for side effect wise, and what it's supposed to do. It's not going to make things perfect. Everyone's still going to have a bad day. But really setting the tone initially and letting them know if there's something we don't like, we can change it. We can adjust dosing, do a different medication, or not doing anything at all if we don't want to anymore. That's okay.
The thing that I always like too is when you talk to parents about the way it works and the expected time course, it's not like a SSRI where we give it a couple weeks, we hope that we start to see a difference within 2 weeks. Like if they're on the appropriate dose, you're going to see results in an hour.
Hmm.
And that also means that it's going to wear off shortly too, which means we're not committed to this for life. We're not even committed to it for 24 hours. And so there's always the opportunity to say, okay, we didn't like this or something didn't go right, but it's going to be out of the system in 12 hours. So I kind of try and tell parents that like this is we're going to do this. It seems like it's the right approach. It will be an experiment to see how they respond. But the good news is most respond well and it wears off quickly.
That is exactly what I say too, to let them know it's not something that's going to last all day, every day, for weeks at a time. I say it's not like blood pressure medication where it's just in your system and it's there the whole time. I set the tone where this is how many hours this specific medication is going to work. It's kind of like coffee, it only lasts maybe for so many hours, then it wears off, you're back to baseline. And if there is something we don't like about the medicine, that's also a good thing for us because it'll be out of the system within a few hours. And usually they feel more comfortable knowing that as well, where you don't have to wean it off, titrate it to get it to a certain level in the system. I think they feel better.
Okay, so let's talk medication specifics because I think that is a place where a lot of physicians feel uncomfortable or they feel like I've only got one tool and if that tool doesn't work, refer right away. Um, what would you say So let's just kind of break it down with the different subtypes. So if we have the inattentive subtype of ADHD, garden variety, 7, 8, 9 year old, somewhere in there, they started off school, yeah, they're kind of like this. And then eventually it caught up with them and it was interfering at home, it was interfering at school. We feel comfortable in our diagnosis. Inattentive type ADHD, what's the first tool in the toolbox that we reach for?
So the first line with that type is going to be a stimulant medication. And so with that, there's the two classes, the methylphenidate, the amphetamines. Obviously, I always go with the methylphenidate first. So that's going to be something for that age group, as long as they're able to swallow pills. Probably Concerta. It is a really good medication. You want to make sure though it doesn't last too long for them because we don't want to impact their sleep. So that's something to consider because that lasts about 10 to 12 hours. But that's a great option to start if you want something that doesn't last maybe as long. You could do something like Focalin XR or Metadate CD. Those last about 6 to 8 hours depending on the child. But always a methylphenidate first. Then if that doesn't work for whatever reason, you titrate it or there's too many side effects, then I go with the amphetamine. And that really helps target the focus the best compared to non-stimulants.
Okay. So you're saying you would jump to Concerta plus or minus Focalin XR or Metadate, which is what I do. I usually do because I had a lot of preceptors in my training that used a lot of Focalin XR. Like that's my go-to, and then Concerta after that. And sometimes I switch it up depending on all of those sorts of things. What about so then what if we talk about more of those impulsive kids that are not necessarily having as much inattention issues, but they're more on the impulsivity issues?
So, more for impulsivity, I find that a non-stimulant can target that really well. And it also can help with some emotional dysregulation that can be impulsive in nature as well. So, the non-stimulant that I prefer to do it or prescribe is guanfacine that really targets that aspect really well. And you can do either the extended release, which is called intuitive, or you can do the immediate release, which is just 10x. And that one you can use to kind of target a specific time frame. If there's a few hours where you're like, oh, the evenings are so hard, giving it at that time can be really helpful. But guanfacine is really great for impulsivity.
And so when you start that, so the guanfacine, like if you can get your hands on the once a day dosing, which often insurance bulks at, because of the cost, then so let's say you can't get that, you're going to do twice a day, or you're going to start in the evenings, or you're going to start it before their main symptoms. What's the timing like from day zero on that?
Yep. So the timing for guanfacine 10x, the short acting, I start it once a day in the evenings just because it can make kids a little tired, especially with that form because it's a little stronger and it's kind of released more in that first 3 to 4 hours versus long acting, which, is about 18 to 24 hours effective. So I started only zero point 0.5 or half a tablet around 3 to 4. So maybe like early afternoon, evening time. And I do that for about a week or so, depending on, when the kid gets home from school and how they're doing with that, if they're able to take it, if a parent's there to give it to them. So after about a week, if they do okay with it, and we're like, okay, well, that time's going okay, but the morning or throughout the day, we're still struggling and they're not too tired, I'll add a morning dose at that point. Again, another zero point 0.5 or half a tablet. And then I see how it goes. I might adjust the timing of that second dose around 3 or 4. I might push that up to a midday or add a midday dose because, again, it's the best at 3 to 4 hours after you give it. So sometimes you need to give it a couple times, 3 times a day. It depends on how that child metabolizes it.
And so so let's say I start with an late afternoon evening dose, would you expect there to be an improvement in their impulsivity the following morning? Like, is there any residual or not really? You would expect them to be back at their normal impulsive childness in the morning for school the next day.
So it depends on the kid, but I will say most probably need a morning dose as well. They may have a little bit of residual effect still from that evening dose, but most still will probably need something in the morning. And with guanfacine, you probably don't see the full benefit until after maybe a couple of weeks that the child's taking it, because that is one you have to give every day for it to probably work the best.
Okay, and can you elaborate a little bit on guanfacine versus clonidine? Is there a reason, like, is there a special case where you would use clonidine, or would you just throw that out of your toolbox and just always use guanfacine?
Personally, I don't use a whole lot of clonidine because it tends to be more sedating for kids. That's really the biggest reason. So some people might use it for sleep. That's why you see that prescribed. But during the day, that's not a great thing. You don't want the kid to be asleep, and it tends to make them more cranky or irritable because they're tired, especially if you add like a tiny morning or daytime dose. So I use that kind of as a last resort when I'm thinking about something else I want to do for some of these kids, because it's just usually not effective and it just causes more problems during the day.
Okay. So I feel really good about, the inattentive type, we're going to do stimulant. For the impulsive type, we're going to do a non-stimulant like guanfacine. One more question about the guanfacine is, if you can get the extended release, does it matter if you give it in the morning or the evening? What's the preference there for the intuitive?
So I tend to start that one also around 3 or 4, just in case, because it can still make a child tired, but it peaks after about 6 hours that they take it. So if it does make them tired, that's going to happen the most at that 6 hour period. So during bedtime, if they adjust to it, it's been a couple weeks, they're okay. Then I move it to the morning. If they want to do that, that's okay.
Awesome. What about combined type, where you have features of both?
So with combined type, I'd probably go with the stimulant medication as well, because again, we really want to target that inattention, that focus, and a stimulant is going to work best to target that.
So again, going back to the Concerta or the Focalin in those cases,
Mhm.
is there ever a time where you would double up, or not double up, but use both a stimulant and a non-stimulant? Um, or are there specific times when a pediatrician, family practice doctor would say, we've made some progress, but I'm going to add guanfacine to your Concerta?
Yes, I was just about to mention that that combination can be so great for some kids, especially with the combined type. So, yeah, you give that stimulant medication, it lasts for so many hours. And then by the evening, when they get home, things are just, in disorder again. And getting through the evening routine, bedtime routine is really a struggle where, it's hard for the parent to get through that. It's super frustrating. Or let's say the kid, again, has a hard time regulating their emotions. And so it's just really stressful for the family. That's when I would probably use guanfacine in combination with a stimulant. Sometimes even that short acting version to target that specific time, because we don't want to add another stimulant after, probably 3 p.m., because then
Right,
we're going to lead to sleep issues. So that
right.
at that time could be helpful. Or let's say during the daytime, we have pretty good focus control, or we're doing better with that, but we're still having some residual hyperactivity and impulsivity, or emotional dysregulation, and we don't necessarily want to increase the stimulant, maybe because it could be too much, we think, or they might have decreased appetite and we don't want to increase it for those reasons. Then you can add that guanfacine as well, because that combination can be really helpful.
Awesome. This has been so helpful. And I think it's just like those tools in your toolbox that you feel comfortable with. Again, the same way that, like, you get out into practice and you always sutured with a 4-0 or a 5-0 or 6-0 for that sort of thing. Like, once you feel comfortable with that, then it makes it really easy to do those things where you're not just waiting on the referral and, oh, I wish I could help you, but I don't do that sort of thing, or I don't feel comfortable with that. I mean, obviously you want to refer appropriately, but you want to over refer to the detriment of your patients and their achievement and their self-confidence and their all of the different things that come in with being able to focus appropriately in school. You said you have a PDF. Is that something that I can get my hands on, like the cheat sheet PDF that you had mentioned earlier? Like, is that available to, pediatricians, family practice people that need it?
Yes, it is. So if you go on my website, you can download the cheat sheet there. And
Okay.
my website is drangelicarobles.com.
And then do you do anything else for people? Like this has been a good like, the main tools in the toolbox, the hammer and the screwdriver, but there's a lot of more specific nuances. Um, Anything else to share or resources to direct people to? I know you have an Instagram that is Dr. Robles underscore developmental peds, and I know you have your website that you mentioned too. Is there any other resources for pediatricians or family docs or those that want to learn more?
Yep. So I also have a Facebook group. It's Developmental Pediatrics for Primary Care that I started about a month or so ago because, again, I want to help with this problem. I see it, I know it's hard. And so I'm putting resources on there as well and trying to do monthly chats so we can talk
Awesome.
about different topics and you can ask questions and I'll cover those as we go along.
And so people can just look up, I'm sure if they just Facebook search developmental pediatrics for primary care, then they can find that group and then, learn from you and from others in the group. That's awesome. That's such a good resource too, because it does feel like you're out on your own, honestly. A lot of the time, even if you're in a group, like you don't like, I mean, there's some to like the collegiality of it, but you also don't want to look dumb. Like, there's certainly a pride aspect to asking for help when it comes to those sorts of things, which I think does lead, honestly, to people referring because it's out of their comfort zone. They don't want to ask one of their colleagues because it might show their cards that they don't know what they're doing as much as they portend to. But having that group as a way to just like connect with others in primary care that are in the trenches, see what they're dealing with, see what kind of questions that they have. You probably have the same questions too. I love that.
Mhm. Absolutely.
Awesome.
Yeah. So feel free to ask any questions. There's no judgment. It's collaborative and I won't judge you, I promise.
Yes, indeed. And anything to keep them from, waiting in your waiting list for garden variety ADHD, I'm sure is appreciated too, so that you can focus on your zone of expertise, which is a lot of the more complicated things, I'm sure. And you want to have room for all those patients that need those really specific evaluations that clog up the system if you are having a lot of things that could be handled in primary care comfortably, safely, and effectively. If they can stay out of your list and off your books, then that will be better for everybody.
Yes, absolutely.
Awesome. Okay, well, I'm going to tell people go to developmental pediatrics for primary care, go to drangelicarobles.com, get that cheat sheet, go from there, and best of luck as the winter season of ADHD approaches and everybody comes out of the woodwork wondering if their child has ADHD this year.
Thank you so much.